and he's going to be talking genetic testing as a new form of non-invasive prenatal diagnosis for detecting DUP15Q and similar disorders. Welcome, Dr. DeBaudet.
Okay, well, I think I'm going on a dangerous edge here, talking about prenatal diagnosis in this kind of a meeting where there are many children affected with severe disabilities, and I think the desire is to focus on cures. So I hope you'll bear with me, and I hope I don't offend anybody too seriously. I'm involved with the Baylor Genetics Diagnostic Lab and have been involved also in starting a company called Libra Genetics, which is aimed at doing prenatal diagnosis of the type I'll show you. So I think a lot of the comments I have here will kind of fit with things that you just heard. So what would it take to really have a cure-like phenomenon for 15q? I think in genetics it's always good to try to correct the core abnormality, so things like getting rid of the isodicentric or going at the core problem as opposed to a downstream problem. You could think about knocking down UBE3A and other genes in the region, which came up in Stormy's talk. We don't really know how many genes you would have to knock down, but we could make some good speculations. How early would you need to start treatment? Would you need to start in utero? Could you start at birth? 15q duplications, it's a very complex story, many variations of this. And it's more challenging than Angelman, Prader-Willi, or other disorders where in utero irreversible injury may be a greater problem. So this is my slide to try to make the message that what you really want to do is try to correct the basic genetic defect in a genetic disorder if you want to try to achieve a cure. You might think that's pretty obvious, but the enormous amounts of effort are being spent in other kinds of ways. Here's an attempt to just show that maybe this came up in a discussion at a Fragile X meeting at NIH. You would have a gene product, and green would mean everything is happening normally. And over here you could have the mutant gene product, and there's a whole bunch of downstream abnormalities. And for something like Fragile X and UBE3A, we suspect the downstream targets are extensive and complicated. So my point I'm trying to make is that downstream therapies for these kinds of disorders, where you come in and I think there's an outstanding example where millions of dollars have been spent with mGluR5 receptors and Fragile X syndrome, is really not a very promising strategy in my view, although it remains highly sought after. Much more appropriate would be to try to activate the copy of the Fragile X gene that's there. This would be where you would turn on the gene and everything goes back to normal. And the more one could get everything back to normal at a genetic level, the better the prospects for an effective treatment. This is a Fragile X syndrome patient. And this is a website that I found interesting. It said, Fragile X syndrome is a genetic condition, so it cannot be prevented. And I must say, I'm going to talk to you about prevention of many of these disorders. And in the case of Fragile X syndrome, and for all severe inherited phenotypes like Fragile X syndrome, it would be possible to completely eliminate these from the population without a single abortion if you made extensive use of pre-implantation genetic testing. And so and yet when I've tried to bring this up at the NIH, they say, that's not our agenda. We're here to cure patients with Fragile X. And I said, don't you care about the patients with Fragile X that are going to be born 5 and 10 years from now? And the answer is no. Okay, so somebody someday ought to care about this. So as you heard from Stormy, you can knock down just about any gene or set of genes you want. You can do it with siRNA. You can do it with ASOs. But as this is a slide stolen from her, it's clear that UBE3A is one candidate for the DUP15 patients, but whether you need to do 2 other genes or 10 other genes is really relatively unknown. There's many genes in the region, as again you saw from the previous presentation, and there, in the lower portion here, there are some differences about duplication sizes, and that's shown further in the next slide. Oh, so this is, there's another strategy to get rid of the chromosome or silence the chromosome. This is an older publication about how one might silence the extra chromosome 21 in Down syndrome, and the idea is to try to knock in this case, an exist region and silence one of the chromosomes. You could think about getting rid of the extra chromosome, silencing the extra chromosome. These would all be very rational strategies for treatment of DUP15. This is just to say it's complicated. You saw this from slides in the previous presentation as well, and it's even a little more complicated than I thought. Here's a report about octosomy and hexasomy of the region. And so depending on exactly how many copies the patient has and so on, the therapy would have to be customized. So a cure for DUP15 is among the most challenging kinds of things. But cures are coming. Here's a slide for gene therapy for spinal muscular atrophy. They come at a cost. The company has suggested charging $2 million for treatment of this type. There are also oligonucleotide approaches to SMA. So there is a lot happening. And this issue of Science arrived on my desk yesterday. It's from July 5th, the bottom portion is. And it's talking about CRISPR, which you just heard about, how one could correct mutations with CRISPR. One could try to get CRISPR to help knock out chromosomes, activate genes, inactivate genes. All of this is very attractive and hopeful. But this perspective is, I've already alluded to this. On the one left, we have a picture I took from the website for DUP15. And the families and NIH, and when families go to Congress, everybody wants cures, okay? And I'm all for that. I would love to have a cure for everything. But I am also thinking about the families who will have DUP15 infants 5 or 10 years from now. And what can we do about that? Should we be worrying about it or not? I'm going to talk to you now about non-invasive cell-based prenatal diagnosis. Another thing that came yesterday is, so I mentioned Libra Genetics, which I've been involved in founding, but we haven't gotten very far in terms of funding. But a competitor, Cradle Genomics, was announced yesterday with a $17 million fundraise. And this is focused on using cells from the cervix. So you do a pap smear-like collection from the pregnant woman at as early as 5 weeks gestation and can get molecular information about the fetus. And I'll show you more detail how we're approaching similar things using blood samples rather than cervical samples. So if you think about genetic disorders, they come in various flavors. There's kind of about 20 per thousand, or about 2% of births will have significant genetic disorders for round numbers. Down syndrome is about 1 of that 20. Other aneuploidies and whole chromosome events, or events like DUP15 would be here, where you can detect these by cell-free NIPT, which I'll say more about in a minute. But a number of the deletions and duplications are not well detected by the cell-free NIPT, and as you'll see, amnio and CVS is becoming less and less frequent. Then there's inherited Mendelian disorders. I would say Fragile X would be a good example where all of the parents of Fragile X affected offspring have a genotype you can detect by screening. And then there's de novo Mendelian disorders. Maybe a good example of this would be Rett syndrome. Girls with Rett syndrome where the fathers typically contribute a new mutation. And these de novo events have to be looked at after fertilization. There's no way to detect them prior to fertilization. So if you want to prevent genetic disorders, one strategy could be used for inherited disorders like Fragile X, Duchenne dystrophy, BRCA mutations for that matter, which are relatively mild, but if you prevented them by pre-implantation genetic testing, you wouldn't be dealing with an abortion option, and we could see a huge reduction of the burden of inherited Mendelian disorders if we as a society decided that much more use of screening prior to conception was used and much more use of pre-implantation genetic testing, which I hope everybody understands means in vitro fertilization, testing which embryos have the mutant genotype and which embryos have the normal genotype, and only implanting embryos with the normal genotype. For de novo mutations, it's different. You have to test after fertilization. And while you could theoretically think about saying, okay, well, let's just do 100% of human reproduction by in vitro fertilization and let's sequence the genome of every embryo before we implant it. That's going to be technically possible, but it's pretty hard to imagine that that would be likely in any time soon. Oops. So is it acceptable or even desirable to prevent or avoid genetic disabilities? These obviously are major ethical, social, philosophical, and religious questions. Is it a legitimate public health goal? If the NIH says that's not our territory, should CDC say we are interested in, they say they're interested in preventing birth defects, but obviously it's politically highly inflamed as to whether that includes termination of pregnancy. I think that most people in the US would say families need to be allowed to make their own decisions. The autonomy of the parents is paramount. I certainly think if we can avoid abortion where possible, I think it's desirable to do so. I think that we should have a healthcare system that funds pre-implantation genetic testing if one of the parents has a high risk of transmitting a genetic disease. That could be cystic fibrosis. It could be BRCA mutations, which let's say there's a couple, the man has a BRCA mutation. They don't want to transmit the BRCA mutation to their children, so they decide we will do in vitro fertilization and we will only implant embryos that don't have the BRCA mutation. And then if you did that for one generation, we'd be done with BRCA mutations effectively. I think also we need to acknowledge that the availability of in utero treatment is becoming a more and more realistic possibility, and certainly if there was a definitive beneficial treatment for DUP15, I think we would want to implement it before birth, if at all possible. But it's not just about abortion. One thing that I don't think there is any role for is embryo correction. So now you do in vitro fertilization with a couple at risk for cystic fibrosis, and 1 out of 4 embryos has cystic fibrosis and 3 out of 4 are normal, and somebody who wants to make headlines says, I want to correct the mutant embryo and put that in. I think in that case, the risk-benefit is much, much better to just implant an unaffected embryo. And in virtually 99% of these cases, you can just put in the healthy embryo. And things about embryo correction, I think, are really not very practical to discuss at this time. There's more and more possibilities for prenatal therapies, newborn therapy, and so on. And I think there's consensus that early intervention for infants and toddlers is highly desirable. So my view is we should diagnose everything in the first trimester of pregnancy, ideally 8, 9, 10, 12 weeks gestation. Just to give you some perspective, there's about 3.8 million births a year in the US, about 17 million in China. And I mentioned that there's fewer and fewer amniocentesis and CVS procedures going on. That's shown here. Since about 2011, this cell-free NIPT test has gone up, and amnio and CVS has gone down. I think this is dreadful. It's a commercial ripoff to offer a test that is not in society's best interest, not in the patient's best interest. I think that what's happening is a woman has a first trimester screen that's positive. She's told you have a choice between an invasive test and a non-invasive test. She says, okay, it sounds like if it's my choice, I'll go with the non-invasive test, right? But they don't tell her that the invasive test would detect a lot of things that the non-invasive test is not going to detect. And so I think that if you have any colleagues who are thinking about having prenatal diagnosis in the near future, if they want as much information as possible, they should go with amnio and CVS and not with the NIPT test, for which there'll be over 1 million tests done this year in the United States, or about a quarter of the US pregnancies. There are high false positive rates and false negative rates for the test. I particularly like Mark Evans in New York has been a strong advocate of how bad the current test is. He talks about the epidemic of abnormal copy number variant cases missed because of reliance upon non-invasive prenatal screening. So I think that some of us feel we should talk that amnio and CVS is very safe, and we should convince people, A, to counsel somewhat differently and have a higher percentage of people choosing amnio and CVS. But that's very unlikely to happen. So my feeling is we have to have a non-invasive test that is as good as the invasive test. And that's where I think we're trying to get. So the cell-free test that I've been bad-mouthing uses DNA floating in the mother's plasma. And in our case, we want to use fetal cells floating in the mother's blood. Here, this is a cytokeratin positive fetal cell coming from, it's usually embedded here near the white cell layer. And I'm going to talk about single circulating trophoblast analysis as an attractive form of this kind of diagnosis. So we're calling this single circulating trophoblast, or SCT testing, as a new form of prenatal diagnosis. We're currently collecting 40 mils of blood. That's quite a lot of blood. We go through, and I think we don't have the time here, but we go through using magnetic bead strategies to pull out trophoblasts and then take individual trophoblasts, do whole genome amplification, and look at the copy number of those. These are 8 cells from a blood sample from a woman. This is a slide from a long time ago. We use the cytokeratin staining to distinguish the fetal trophoblasts from the mother's white cells. So how do we determine copy number? We make a shotgun random library of DNA fragments. If you get about 5 or 6 million reads, you can get quite good copy number data. You plot it out in this way with bins. And what you can see here is a case of trisomy 13 in a male. Here it's compared to a female control, so there's a loss of X, and you'll be able to see in some subsequent slides the gain of Y chromosome. This is one cell. Every plot I'm going to show you is one cell. Here's a male and a female cell. How do we know the sex? Well, if it is a male, it's easy. We see the X and Y changes when we do the analysis of one cell at a time. If the fetus is female, that is not an option, so we have to rely on genotyping. We have a genotyping method that asks, in this cell, how many alleles do you see that are not present in the mother? And if it's a maternal cell, there should be 0. And so over here you have maternal cells where the only signal is coming from just noise. Whereas the fetal cells are well separated, and in this case are over here. So we have data that every single cell is fetal or maternal, and we want even more data than that eventually. So here's just some cases of trisomy 13, or 18, I think, I'm sorry, in this slide. I don't have a slide of dupe 15, but as what we're doing, I will get one coming up here before too long. We'll have a dupe 15, and we'll see what the family wants to do about it. This is trisomy 21. This is just 5 normal male cells to show you the kind of data we would like to have on every single sample. We can't get as many as 5 cells on every single patient right now. So there's development still needing to be done. If there are twins, in this case, a male and a female twin, we got 3 male cells, and you see the Y here and the changing copy number of X here. So we got 2 female cells and 3 male cells. We can also use genotyping to say, is it twin A or twin B if there's 2 males or 2 females. So this is a case that's kind of interesting. The amniocentesis or ultrasound showed findings very suggestive of trisomy 18, omphalocele intrauterine growth retardation. Amnio showed trisomy 18, and we got only 1 cell. So obviously you'd like to have multiple cells, but in this case we got only 1 cell, and it showed trisomy 18. If we have one high-quality cell like this, we find that if we get a 2nd cell or a 3rd cell or a 4th cell, it's identical to the previous cell unless there are twins or unless there is a phenomenon called confined placental mosaicism, where there's multiple cells in the placenta that have mosaicism, as was described in the previous talk. This is the numbers of cells gotten from a whole series of pregnancies. You can see the optimal time looks to be about 10 to 15 weeks gestation. But we do get some positive samples down in the 7 and 8 weeks gestation. Here, 0.2 is 0.2 cells per ml of blood. So for a 40 ml sample, this would be 8 cells here. And then you'd have 4 cells, and then there are a few zeros. We obviously don't like that, and we'd like to improve upon that. This is just 5 cells with trisomy 21. I think we see this test as diagnostic and not screening, which is another difference between the current test and what we're proposing. You see mosaicism. This is a 46XX, 45X sample, and in fact, I can't remember whether it's the amnio or CVS was normal, although the cell-free NIPT also showed the mosaicism. So we do see mosaicism, which is seen routinely in chorionic villus sampling. So these are cases where we have both complete single-cell data and amnio-CVS. We had 30 normals, all of which were normal by both tests, and 6 aneuploid, which were all aneuploid by both tests. So here is some expansion, though. On the previous slide I didn't have, there were 5 normals where our test failed, and there were 3 normals where we detected mosaicism, and I think there really is mosaicism there, and it gets into a complex discussion about how you work up mosaicism and what the implications are. So this is a series we did where this is our best, most recent attempt. We had we had 63% of cases in pilot 2 which had 2 cells or more available, which we consider relatively adequate. And we had 21% with 1 cell, and then a smaller percent with no cell or no cell for deletion analysis. So the advantages of trophoblast testing, it's very early, 7 or 8 or 10 weeks. And I mentioned the cervical test can be early too. So if we are talking about termination of pregnancies, families can have options of medical terminations rather than surgical terminations, and earlier terminations rather than later terminations. It has a very high positive predictive value and negative predictive value, we believe, although we don't have all the data to substantiate that yet. You can get multiple independent cells from a single pregnancy. You can detect multiple cell lines, twins, and mosaicism. And you study one at a time in the case of twins. You don't make maternal diagnoses, which are a big source of false positives in the existing tests. That is, let's say the mother has XXX, but she doesn't know it. Or she's mosaic XXX and she doesn't know it, and she's become pregnant. When you do this plasma test, you see somebody here has got XXX. And often it turns out that it's the mother and the fetus is normal. You can also sometimes detect cancer in a maternal cell or maternal sample. So we think it's very important to analyze single fetal trophoblasts. In the current test, we would like to be able to analyze single fetal nucleated red cells, which would get around this mosaicism or provide a follow-up on cases of mosaicism. But that's more challenging at present. And the cervical method would not get red blood cells as well. So there's a lot of development to happen here, but I think there's a lot of sense that this is going to move forward now. The number of trophoblasts is lower after 15 weeks gestation, but we think that it may be at that gestation better to go after nucleated red cells. Even data on a single sample is highly informative. Data on 2 or more cells is an achievable goal for about 80% of cases right now. Placental mosaicism occurs. It's very similar to CVS. And we have the ability to detect deletions and duplications down to 1 to 2 megabases. I haven't shown you some of the smaller events that we've detected. So I think this testing will revolutionize prenatal diagnosis. We'll have a running battle with the cervical people as to whether you want to have prenatal diagnosis and definitive genome analysis at 6, 8, 10 weeks gestation by a cervical sample or a blood sample. Soon we will sequence the entire genome of all fetuses in the first trimester. If you want to detect de novo mutation disorders, which as a group are about 5 times more common than Down syndrome, and maybe an example of such a condition is Rett syndrome. If you want to detect Rett syndrome, and you want to detect the 500 other genes that do things like Rett syndrome, you have to sequence each embryo in its entirety, or at least in the key regions. And you probably have to do more than 1 cell to be sure you don't have any false positives. And I think that prevention of rare disease through reproductive choice is an important option. Obviously, I'm not sure the mix here. I think it's more scientists and clinicians here in this audience than parents. But to try to bring this message to groups like the DUP15 families, I sort of have shied away from it for a long time, and now I'm sort of saying, well, cures are great, prevention is great, people have to have autonomy to choose between the two. And these are some of the people who've been involved in the prenatal work. Lisbeth here, Inge Vanenwever, Amy Bremen have been very big players. We've been collaborating with Ron Wapner, who's at Columbia in New York. Thank you.